Hi everyone, in this lecture I am going to talk about the management in second stage of labor. So when does this second stage of labor begin? When the first stage of labor ends. It means when the cervix is fully dilated, that is about 10 centimeter. Now this is the time when the fetus needs to come out through the introitus into the outer world. So that is called the second stage of labor. Okay. So in this video we'll see what all principle as well as what all preparation we must need to do and how this second stage of labor could be managed very easily without causing any difficulty for the fetus as well as for the mother. Okay. So as we have seen previously also that in first stage of labor there is a regular uterine contraction with the increasing frequency and the duration of contraction. Once the first stage ends, now these intensity become more increases. They become more intense because the pressure within the uterine cavity also rises, right? Because this is the time in which the fetus is going to be come out, right? So as the intensity of uterine contraction increases during second stage of labor, the woman also have reflexive bearing down efforts. She also wants to push down until the fetus completely comes out, right? That is very important event that we already discussed in our previous video as well. So the principle behind this whole process is that we just assist this process very slowly and steadily because we just maintain the flexion of head. As you can see in my previous video of mechanism of labor that there is a step that is the extension of head. So we just avoid the early extension of head. We just want that there should be a complete flexion once the fetal head is going to be comes out through the introitus. Okay, so to maintain the flexion, we just assist this whole process slowly and steadily without or with minimal aid. That is the basic principle. Now come what all preparation we can do for delivery. Okay, so what is the preparation we must need to do? Firstly, as we already know that the cervix is fully dilated and the membrane is also ruptured now, so woman must be in bed. The basic first step is the woman must be in bed because the membrane is also ruptured and at any time the fetus must be comes out. Now as soon she is in bed, what all things we can do? Firstly, we can assess the vitals of woman, as well as we monitor the fetal heart rate, and it should be in every 5 minutes because we have seen that with the increasing uterine intensity or contraction, the fetal heart rate slows down. When the uterine contraction are at peak, the fetal heart rate goes down, right? That we already discussed previously also. So but it again come back to the normal once the contraction passes over. It return back to the normal immediately, or it comes to the normal baseline, right? So to check out the status of the fetus in relation with the uterine contraction, we monitor the fetal heart rate. Okay. Now as soon she lie down in a bed, what all things we need to kept ready? That firstly we can place a sterile sheet under the buttocks of a woman and one on top of the abdomen, and we just maintain the privacy of woman as well. So we can provide aseptic technique, or we can clean the vulval area, so there should not be any infection to woman as well as for the fetus when he or she comes out. So we can provide vulval toileting, and we can wrap the woman and cover most of the part of the body and expose only that we want, that we can just expose the vulval as well as the thigh area of a woman. Okay. Along with this vulval toileting, the obstetrician as well as midwife also scrub up, and they can use gown, gloves, mask, eye caps, so they can also prevent them from infectious agents, right? So after vulval toileting and placing the sterile sheet under the buttocks as well as over the abdomen, and after this scrubbing or maintaining all aseptic precautions, We also must ask women that she just empty her bladder, and if the bladder is not empty and she is not able to empty, then we must catheterize the woman. So catheterization is very important, because if the bladder is loaded with the urine, then the presenting part won't be able to descend down. Okay, so catheterization must be done if the bladder is not empty. After catheterization, we can go for PV examination, per-vaginal examination, and by this PV examination we can assess the dilatation of cervix. We can rule out any cord prolapse is there or not, or we can check out the descent of presenting part, how much it is descending from the ischial spine, right? So many things we can rule out through this per-vaginal examination. So after all this preparation, we can provide position to a woman, right? So although there are many positions, like in upright position, there is sitting position, then there may be a squatting position, or there is also kneeling position, right? But the most common position which we are generally prefer is the lithotomy position or the dorsal. So most common is the lithotomy or dorsal position with 15-degree left lateral tilt, right? So this is the most common position which we are using, that is the lithotomy as well as the dorsal, but we are using in dorsal the 15-degree left lateral tilt to avoid the compression over the aortovena, because these both positions provide the clear visualization as well. So these are the basic preparation we must need to do as soon the woman is entering in a delivery process. So she must be lie in a bed and maintain all the aseptic techniques, fetal heart rate as well as the vital signs of mother must be recorded. Catheterize the woman as early as possible. If she is not empty her bladder, we can check out the per-vaginal status as well as we can provide a position to a woman in a delivery. Now after the preparation of the delivery, we'll see what all three phases are there in the expulsion of the fetus, because it is not like that once the cervix is fully dilated and the fetus is going to be come out in a single shot, right? So the delivery is going to be take place in a 3-step. Like first the head is going to be come out, because it is the most difficult part, and the most common presentation we already see that it is the vertex. So first the head is going to be come out, and once the head is expelled out, now it is the time where the shoulder as well as the trunk and rest of the body is going to be expelled out, right? So the three phases are, the first is the delivery of head, because the head is the most difficult part which is going to be delivered first, and as soon the head is going to be delivered, next comes the shoulders, and after shoulder there is a delivery of trunk and rest of the body, right? So once the cervix is fully dilated and the presenting part descend down progressively and the scalp hair are visible now through the introitus or the vaginal opening, so we just need to maintain the flexion of the head. That is very important in the delivery of head. So what we need to do is maintain the flexion of head. And how we can manage this flexion of head? By using the modified Ritgen's maneuver. So by using the modified Ritgen's maneuver, we can maintain the flexion throughout this process until the head comes out. So how we can maintain the flexion? We just wrap or cover this right hand with a towel, sterile towel, and with this stretch thumb as well as forefinger, we can place this hand over the anococcygeal region, and by the left hand we can, by this thumb and the index finger, we can push the occipital region downward or backward, and we can just support the perineum with the right hand. So with this maneuver, that is called the modified Ritgen maneuver, with this maneuver we can maintain the flexion until the smallest, because why we are maintaining this flexion, because we just want that this smallest diameter in the fetal skull in the anterior posterior aspect, and the small diameter is the suboccipitofrontal. So we just want the small suboccipitofrontal diameter to comes out first through this introitus, rather the large diameter, that is the occipitofrontal, which is about 11.5 centimeter. So we want this suboccipitofrontal diameter, which is about 10 centimeter, to come out through this introitus. That would be easier for the fetus as well the mother, so she can also push down and the fetus can easily comes out, right? So with this modified Ritgen maneuver, we are using this maneuver to maintain the flexion so that the small diameter can escape out through the opening. Okay, so as the scalp hair are visible and the small diameter is going to become out, this biparietal diameter, the transverse diameter in fetal skull, stretches the vulval outlet, and as this biparietal diameter stretches the vulval outlet, the perineum becomes circular, it becomes thin, stretched, glistening, right? So this stage here, this stage is known as crowning, because this part is going to be visible now. Okay, so once the crowning occur in some of the women, like especially in primary gravid women, because in them the perineum is more rigid, right? So in primary gravid women or in rigid perineum, we usually perform episiotomy because we don't want any laceration or tear. So to avoid the perineal laceration, we are using episiotomy, that is, we are just cutting the perineum, and the most common site we are using is the mediolateral. That all we discuss in another video about the episiotomy. So we are using episiotomy in mediolateral direction to cut the perineum and to make this opening more enlarged so that the fetus can easily comes out when the perineum is rigid. Okay, so this is the ideal timing when the contractions are at a peak and the crowning takes place and the perineum become thin, bulge, shining. At that time only we just perform the mediolateral episiotomy, right? So this is the short thing that we all discuss in later. So as the scalp hair are visible and the perineum become bulge, we are performing the episiotomy, and once the episiotomy we are performing, what is happening with this slow flexion, with the steady flexion, finally the forehead, that is the sinciput, and then comes the nose, and then the chin, finally borne by the movement of extension, right? So first phase, that is in second stage of labor, is completed here. That is, the head is going to become out, and this is come out by the movement of extension. So once the head comes out, now what we need to do, once it is comes out, we just clean the mouth as well as the pharynx of the fetus if the mucus is excessively collected, and we can use suction as well as we can wrap the little finger with a sterile gauze, and we can clean the mouth as well as the pharynx of the fetus, and also we can use the dry cotton swab to clean the eyes. So by a single stroke of each cotton swab, we can clean the eyelid from the medial to the lateral canthus, one stroke in each side, and finally we can wipe the mouth area. So as the head is born, there is a pause, and after a pause the woman again start up with the uterine contraction, and she also have urge to push down. So with the little pause, there is again uterine contraction, and as the contraction begin, there is a movement of restitution. The head turns obliquely in any of the thigh direction, and once the head turns obliquely, again there is a movement of external rotation of head. The head turns transversely, completely it is moved transversely, right? So as the external rotation of head takes place, that indicate the internal shoulder also rotating inside, that the bisacromial diameter, that is the diameter between the shoulders, okay, so that indicative the shoulders are also lying in the anterior posterior diameter of the pelvis, okay. So once the shoulder lies in the anterior posterior diameter, the head is also rotating externally, and that is visible externally. So external rotation of head is accompanied with the internal rotation of shoulder, okay. So this takes place as the head turns sidewise, right? Now as the head turns, what is happening? Next comes the delivery of shoulder, okay. So although it is not difficult for the shoulder as well as for the trunk and the rest of the body to deliver out, but in some of the condition, if it is not easily comes out, what we can do? We can grasp the head in between the hand, and firstly we can posteriorly tilt the head slowly so that the anterior shoulder can escape out, and as the anterior shoulder sweeps the perineum, now we can upward lift the head so that posterior shoulder also sweeps the perineum. So this is how both the shoulders are born, right? And the rest of the trunk as well as the body is also delivered by the movement of lateral flexion. So this is how the three phases of the fetal expulsion is now completed, how the head and then after the shoulder and the trunks comes out by these all movement. But one thing we must keep in mind, that this traction should be very slow and gentle, because if we are using very harshly and we are going in a very hurry, then it could be fracture the clavicles of the fetus, or there would be a hematoma formation, or there may be the injury to the brachial plexus also. As soon the baby is going to be delivered out, now we can clean the baby and we can cover the baby in a dry warm towel and place in a sterile tray, and that tray could be placed in between the legs of the mother. It could be in a lower manner. So by lowering the head of the baby, the mucus which is collected inside the mouth of the baby also comes out, or we can use the suctioning as well, because if once the baby is trying to inspire, that collected mucus can be aspirated, okay. So to avoid this, we can lower the head of the fetus, and by lowering the whole body of the fetus also helps to collect good amount of blood from the placenta, because it with this gravitational force, the placenta draining few amount of blood from placenta toward the fetus as well. After that, we just assess the Apgar score at 1st or 5th minute of birth, and by this we can assess how well the fetus tolerated this whole labor process. So after the Apgar score, we are just clamping the cord of the fetus, and it should be away from the abdominal wall at least about 6 to 8 centimeter, and we are using Koch's forceps to clamp the cord, okay. So it should be 6 to 8 centimeter away from the abdominal wall, and once we clamp at both the end toward the fetus and toward the maternal side, because from maternal side, if we are not clamping the cord, then the blood could be spill up and it could soil the linen, right? So we clamp both the side and cut in between, and after cutting we are just ligating the cord, and the ligation should be 3 to 4 centimeter away from the abdominal wall of the fetus, right? In some of the studies, it is said that delaying of cord clamping is good for term as well as preterm babies who is more than 30 weeks of gestation, because it provides good source of blood, as it is transferring about 80 to 100 ml of blood, and that can prevent anemia, and that also reduces the need for blood transfusion in the babies in otherwise situations. But we are not using in very premature babies who is not completed 30 week of gestation, as well as low birth weight babies, or in even in RH incompatible babies, or babies of diabetic mothers, because in RH incompatible babies the antibodies could be transferred easily if we are delaying the cord clamping. And if the baby is of low birth, or if it is more premature, then that could be lead into the hypervolemia. So this increased volume can lead into the more bilirubin formation, so that can cause hyperbilirubinemia. Or if the baby is having this condition, then the hospital stay would be increased, because there would be a need of phototherapy as well. After the cord clamping, this is the time in which you can tag the baby with this identification card, and you can transfer the baby to the mother, right? So here we have seen how we can manage the second stage of labor, what all preparation we must need to do before the delivery is going to be take place, and in 3 steps, that what all 3 steps are there. That first the head is going to be delivered out, and then shoulder and the trunk, that the rest of the body is going to be delivered out. And after the delivery of baby, we just maintain the temperature of the baby by providing the warm towel to prevent from the hypothermia, and we can check out the Apgar score to check out the status of the fetus outside the womb, and we can clamp the cord and separate the baby and give it to the mother. Thank you.